Hello one and all. Welcome to YOTube, the official YouTube channel of Young Ophthalmologist Society of India. I am Dr. Zain Khatib, an ophthalmologist practicing in Mumbai and an executive member of YOSI. So we are aware that a few months back in March, between 12th to 18th March was the World Glaucoma Week. During this period, all of us ophthalmologists took out some time to do a small bit for increasing awareness of this extremely complicated disease glaucoma. But in this video, we are going to do something different. We are going to increase awareness of a very new entity in glaucoma among fellow ophthalmologists. What I'm talking about is MIGS, which stands for Minimally Invasive Glaucoma Surgery. Now, MIGS is something that we have been hearing for quite some time from the Western world, but never really understood much of it. So today we have with us a very special guest who is a young, dynamic and extremely prolific glaucoma surgeon. In fact, she is considered one of the pioneers of MIGS in India. Being one of the first few surgeons from India to perform MIGS is Dr. Sahebaan Sethi, practicing at Anurodhaya Deseret Eye Hospital, Gurgaon. She has graciously agreed to speak with us on MIGS and answer a few questions related to the procedure. Welcome Dr. Sahebaan to YOTube. I hope you are happy to be here and we are going to ask you a few questions related to MIGS surgery.
Thank you, Zain, for having me here, and I'm actually very excited. And what better than talking about something which is buzzing everywhere and now picking up in India as well, the minimally invasive glaucoma surgeries. And I am a big proponent of MIGS, and today the purpose of me talking to you would be to educate everyone, educate the youngsters of our country on what the real truths about MIGS are. I'm not going to be biased over here. I'm going to be very fair, very truthful about the pros and cons of the surgery, and I'm going to try and answer every question that a youngster may have in their mind to open their avenues for MIGS, for people who want to start their journey with MIGS, or generally someone who wants to have a little more understanding about the procedure.
Okay, so Dr. Sahebaan, the first question I'm going to ask you is, can you please tell us what exactly is MIGS? Like, how do you define MIGS?
So when you ask me what is MIGS, let me give you a very clear-cut definition. So the term minimally invasive glaucoma surgery was actually coined by Ike Ahmed. Not that it was innovated by him, these devices have been available, but the category of interventional glaucoma was termed MIGS by Ike Ahmed. It's minimally invasive glaucoma surgery, and it has 5 attributes. Number 1, that all these group of surgeries, these procedures are ab interno, they are conjunctival sparing, and they are minimally invasive using a micro incision. So you can use a side port incision to do any of these procedures of MIGS. The second point is that there is minimal disruption of the normal anatomy of the eye. So this is not like trab, wherein you cut the conjunctiva, you're cutting the trabecular meshwork, you're cutting the sclera. This is minimally invasive and minimally disruptive. The third pointer is that it brings about only moderate IOP lowering. By definition, you are not to be expecting a very high or significant IOP reduction. The fourth point is that it has an excellent safety profile vis-a-vis the traditional filtration surgeries or the tube surgeries that we've been so used to, and the only avenues that we had so far. The fifth point is that there is rapid recovery of patients. So the post-operative course is much less cumbersome. You need to see the patients less frequently. There are minimal to no interventions required post-operatively. The recovery is within a day or two. So these are the advantages, and these are the 5 pointers that define MIGS.
So thank you for defining MIGS for us. So tell me, what kind of role can MIGS have in our current glaucoma practice? I mean, we have surgeries like trabeculectomy, Ahmed glaucoma valve and others. So where exactly does MIGS fit in this?
So what is the role of MIGS in our practice? So when you ask me what is the role of MIGS in our practice, let's understand that this is a very new niche, worldwide and specifically so in India. And when we propagate MIGS, we don't mean that it's here to replace either the medical therapy or the traditional therapy. But MIGS was introduced with the intention that it is going to bridge the wide gap between the initiation of glaucoma therapy with medications and waiting till the patient has a very advanced glaucoma to do filtration surgery. What in between that? So when your medical therapy is not working, you wait for the patient to become advanced and then do a filtration surgery. Why not intervene a little early and save him from going into or progressing into an advanced glaucoma? So this is the area where you apply MIGS for patients who are mild to moderate glaucoma and in whom the medical therapy is either not tolerated or is ineffective, and you don't want the patient to be progressing to an advanced glaucoma to intervene. You intervene there and then and prevent them from progressing further. So it is basically a bridge between the medical therapy and the traditional surgical therapy in the advanced stages. It is not here to replace either of these two. The medical therapy has its own target population. The trabeculectomies and the tubes have their own target population. Similarly, MIGS also has a small spectrum of patients which are its target population, and this is how we want to maintain it.
Okay, so you say that MIGS fits in the middle. Can you tell us who exactly then is the target population for which MIGS is indicated?
So who are these patients that MIGS is most suited for, or what are the indications for MIGS? So generally MIGS is applicable to only mild to moderate open angle glaucoma patients. And when I say mild to moderate open angle glaucoma, it's very important to understand because there is a lot of confusion that I have realized about the staging of glaucoma. A lot of people equate very high intraocular pressures with saying that this is severe glaucoma, or a patient who is on a lot of medications, let's say 4 to 5 medications, they feel this is severe glaucoma. Well, that is not the case. Glaucoma can only be staged according to the visual field findings, which is also very important to do in any patient that you're treating for glaucoma. First, you need to stage it irrespective of the intraocular pressure, irrespective of their number of medications they are on. It is the Hoddep-Parrish-Anderson criteria which tells you what is mild, what is moderate, what is severe glaucoma. So broadly, when your mean deviation is less than 6 decibels, it is mild glaucoma. If it is between -6 to -12, it is moderate glaucoma. Above 12 becomes severe glaucoma. So the mild to moderate category is what we suggest or what we recommend should be given the option of MIGS, not beyond that. Any patient who has severe glaucoma, let's understand, will only benefit from trabeculectomies because that still stays the gold standard for treatment in a advanced glaucoma. So having said that, now we're clear that this is mild to moderate open angle glaucomas. Pseudoexfoliation and pigmentary glaucomas also benefit from MIGS to quite an extent. All other secondary form of glaucomas are contraindicated.
Okay, good. So right now I'm pretty convinced that MIGS has a role to play after hearing you. So can you tell me, if I want to learn MIGS, from where and how do I learn to do MIGS surgery?
Well, where you should learn MIGS from, I think to start off with, watch a lot of videos. There are a lot of videos that are available for, not a lot I would say, but enough for you to be familiar with what I'm talking about, what the procedure looks like. So yes, read about the procedures, watch videos. This is where I think you can start off with. Otherwise, if you're genuinely, seriously interested in learning MIGS, you can come to my center. I have had people who've come to observe me they have been given a chance to actually do a few cases of bang as well. So yes, you can get in touch with me. I can help you out in your journey, and then you can maybe continue with your own patients. I'm always available for any query, for any guidance that you may need. My hospital is in Sector 55, Gurgaon. It's by the name of Arunodaya Desert Eye Hospital, and we have regularly lot of camps, a lot of glaucoma patients walking into our OPD, on which you can observe cases of MIGS, you can do cases of MIGS, and I almost do all cases of MIGS except all techniques of MIGS except the ECP and the trabectome, the equipment that I don't have and I don't plan to buy. So yes, you can get in touch with me, you can get in touch with Zen to contact me, or you can directly message me and I can help you out.
So thank you for that. I'm sure that those who are watching this video are all going to be asking for your contact details to learn MIGS from you. But in all seriousness, can you tell me that what skill sets are needed for an ophthalmologist to start MIGS?
So what skill set do I need to start off with MIGS? Okay, so I think as a glaucoma surgeon, you will be very familiar with doing slit lamp gonioscopies. So now is the time to start doing surgical gonioscopies. So every time you're doing a cataract surgery, at the end of cataract surgery or before your cataract surgery, just position the patient and see the angle. You need to acquire a surgical gonio prism before that, and like I said earlier, it can either be a Swan-Jacob gonio lens which stays with you. This is a permanent lens which can be autoclaved any number of times that you want, or you can get hold of disposable gonio lenses which can also be ETO'd and used for at least about 6 to 10 times depending on what lens you are procuring. And start off visualizing the angle first. I feel personally that you need to see at least about 30 to 50 angles for you to be familiar with visualizing the angle clearly, for you to be familiar with the landmarks in the angle, for you to be familiar with what exactly is the trabecular meshwork, where is going to be my target for MIGS. So positioning of the patient is something that you need to learn. Visualizing the angle is something that you need to be very familiar with. Also the hand-eye coordination, holding the gonio lens with the left hand, having a good maneuverability with your lens is also something that you have to practice. It comes with patience, it comes with practice. So get down with it, visualize, use your surgical gonio prism. After you've crossed that first stage, then comes the stage of having a good hand stability around the angle. So my advice is that after you're familiar with visualizing the angle, you know exactly where the trabecular meshwork is, your aim for the next 10 cases should be just take a visco cannula, go close to the angle and just play around, just inject visco, maybe touch the trabecular meshwork very lightly. What you're trying to achieve with this is that you want to be very comfortable with your hand movements, because let's understand that this visualization is under extremely high magnification. So a good hand stability is very important. Your left eye will be holding the surgical gonio prism and your right eye has to be rock stable so that you don't injure other structures around it. Even the entry has to be very carefully done so that you don't nick or you don't strip the anterior lens capsule while going inside in a phakic patient, or you don't damage the iris while going inside. So just after your visualization is comfortable, get comfortable with micro movements with your hands with the visco cannula. Next stage will be to start doing bang. So I think bang is a brilliant, good technique to start your MIGS journey with. So just take a needle, bend it away, a bang needle has to be bent, and then start stripping the trabecular meshwork. Initially you can aim up to about 90 degrees of trabecular meshwork treatment, and then maybe you can progress to a 120 degree of treatment area, which is usually sufficient for any of these trabecular excision procedures.
Okay, so Dr. Sahebaan, we need to understand what are the potential complications that MIGS can have. We've heard the rosy picture, but we need to know about the complications as well.
So, what are the complications of MIGS? Most commonly, if we are going to talk about intraoperatively, most commonly you see in about 100% of cases some sort of intraoperative hyphema. Now that is a desirable endpoint of a successful surgery, because after you've bypassed the trabecular meshwork and made a direct communication with the Schlemm's canal, you do expect some sort of reflux bleeding from the Schlemm's canal, which is a desirable endpoint and can be completely managed intraoperatively. It's not going to be a ghastly hyphema anyway. Post-operatively, you may see microhyphemas which are transient and can be managed very well medically. You may see IOP spikes post-operatively, you may see steroid response post-operatively. All of this can be managed medically, and almost never do you need a surgical intervention to take care of these problems. Then also another major concern, especially after bang, after trabectome or KDBs, which are the trabecular meshwork, or even after GAT, which are trabecular meshwork excision procedures, you see peripheral anterior synechiae. So that is another complication you may see. One way to ward off this complication or to reduce the chances of it is to start your patient on pilocarpet post-operatively, so that the peripheral iris is pulled away from your treatment area and the occurrence of pus is reduced. Apart from this, if there could be stent-related, device-related complications like malposition, obstruction. There can be regular surgery-related complications like endophthalmitis. All of this is very rare because MIGS is a very safe procedure, and all of it mostly can be managed medically.
Okay, so now that we have understood the basics of MIGS, we have all our concepts regarding it clear. But now let's talk about the surgical part. I have heard that during surgery, the head needs to be in a slightly different position than from routine surgeries. So can you elaborate a bit on that?
So how do you position your patient for MIGS? So MIGS can either be done at the beginning of cataract surgery or at the end of cataract surgery. If you're doing a standalone MIGS procedure, then in that case there's no problem. The surgeon has to be sitting on the temporal side of the patient. There is a microscope inclination that is possible, so you have to tilt the microscope by turning the knob towards you about 35 to 45 degrees towards you. Now there are certain apps that are available. If you're using an iPhone, there is a measure app which tells you about the angulation. So for the first time that you're doing it, you can measure how angulated is it, bent 35 to 45 degrees towards you. After you measure it, you can make a mark on your microscope, so that every time that you tilt the microscope, you don't really have to have your phone or have your assistant measure how much you've tilted, and all this, it won't be cumbersome anymore. So you can just have a mark and do it according to that, align those two marks, and you know that it is tilted 35 to 45 degrees towards you. Positioning of the patient has to be, when you're sitting temporally, the head of the patient has to be turned 35 to 45 degrees away from you. So be very careful with patients who have neck issues, who have cervical spine issues. Counsel them before that. Probably avoid these patients who can't be comfortable in that position. So you have to rotate the head of the patient 35 to 45 degrees away from you. You have to be sitting temporally, and a temporal incision has to be made, and then you go in, you hold the surgical prism with your left hand, you go in and you start doing your procedure with your right-handed for a right-handed surgeon.
Thank you, Dr. Sahebaan, for explaining about the head position. So now let us see an actual surgical video where Dr. Sahebaan demonstrates how MIGS is done. What is the surgical part where she is doing an eye stent.
The patient was positioned for the MIGS procedure. For this, the patient's head is tilted 35 to 45 degrees away from the surgeon and the microscope is tilted 35 to 45 degrees towards the surgeon. A direct surgical gonioprism is then placed onto the cornea using cohesive viscoelastic and angle structures are to be clearly visualized. Excellent visualization under high magnification is of paramount importance for this procedure. Through the same phaco-incision, after filling the anterior chamber with cohesive viscoelastic, the injector is introduced and directed infranasally. The tip of the injector is retracted and the stent is visualized. The needle tip is then dimpled into the targeted trabecular meshwork area perpendicularly and then the eye stent injector shot. Blood reflux is a good sign. The injector is withdrawn and AC refilled with cohesive viscoelastic and similar maneuver repeated on the supranasal side. Minimal hyphema was noted and washed during viscoaspiration.
That was a beautiful demonstration of surgery, Dr. Sahebaan. So we've understood most of the procedure. The last question I'm going to ask you. How much time does MIGS actually take post-operatively to take effect? In terms of lowering the pressure, how much time does it take?
The peak effect of MIGS will take about 1 month to set in, because pre-operatively the patient has also been on anti-glaucoma medications. So you also want to wait about 1 month to 6 weeks for the effect of the anti-glaucoma medications to completely wash off the eye, and then only will you have a fair judgment on how much the intraocular pressure has dropped, only on the basis of the MIGS procedure that you have done. Post-operatively, if the patient is on anti-glaucoma medications before the surgery, what I prefer to do is take them off all medications completely. Now, because you are using only mild to moderate open-angle glaucomas for your MIGS procedures, they usually have a good nerve reserve. So even if they are on 4 medications, stop all of them. Even if there is a pressure fluctuation for 1 month, because they have a good nerve reserve, it's not like their glaucoma is going to progress or the vision is going to get knocked off, no. But at least you have a fair assessment on how many medications you should incrementally start them on. So after 6 weeks, start them on a PG analog if you feel that the patient has not achieved its target intraocular pressure without medications. And then incrementally increase the anti-glaucoma medications and stop where you feel that the target IOP has been reached. So stop all anti-glaucoma medications post-MIGS, wait for 1 month to 6 weeks to then decide what the target IOP should be, and accordingly start the anti-glaucoma medications one by one.
Very nice. So I think we have a lot of doubts cleared about minimally invasive glaucoma surgery. It is definitely an exciting time for cataract and glaucoma surgeons, with MIGS coming up and evolving in a very big way. MIGS definitely seems to be the future of glaucoma surgery. A big thank you to Dr. Sahebaan Sethi once again for agreeing to do this small educative video as an initiative of the Young Ophthalmologist Society of India. Do subscribe to YOTube, the official YouTube channel of Young Ophthalmologist Society of India. This is Dr. Zain Khatib signing off. Thank you.